Hello, everyone, and welcome to our presentation on prenatal and early childhood home visiting in Maryland. My name is Beth Barnett. I'm a practicing family doctor and professor at the University of Maryland Department of Family and Community Medicine. I'm a member of the evaluation team of Maryland's Maternal, Infant, and Early Childhood Home Visiting Program. I'm delighted to speak with you today about the benefits of home visiting for families in Maryland. In today's 10-minute presentation, we have three objectives. The first is to introduce Maryland's prenatal and early childhood evidence-based home visiting programs. The second objective is to identify the benefits of improving coordination between home visiting programs and primary care medical homes. And our third objective is to share what we have learned so far and the critical role that we, prenatal and primary care providers, play in connecting families to these important services. When I speak about evidence-based home visiting here, I'm referring to a service delivery strategy that is designed to reach expectant families and families with small children prior to school entry. Home visiting programs target high-risk families and generally have goals to improve maternal and child health, school readiness, the quality of parenting, and family economic self-sufficiency. Home visiting has been around for over 100 years in various forms as a means of addressing child health and developmental issues that arise out of urban poverty. But over the past 4 decades, research has helped shape what effective home visiting delivery should look like in order to be most effective. Many models of home visiting have been developed and evaluated over the years. The United States Department of Health and Human Services has designated 17 different home visiting models as evidence-based. Baltimore has chosen to use 3 of these models. They're called Healthy Families America, Early Head Start, and Nurse-Family Partnership. These models all target high-risk families, but they differ in their service delivery strategies. For example, Nurse-Family Partnership uses nurses to provide home visiting services, while Healthy Families America uses trained paraprofessionals as home visitors. Most models enroll families prenatally, though some may enroll just after the baby's delivery. And visits continue until the child is 3 to 5 years old. The purpose of these home visiting programs is to prevent infant mortality, promote maternal mental health and positive parenting, and advance child socio-emotional well-being and school readiness. This map gives a view of the more than 70 home visiting programs across Maryland that are shown in red. Many are located within health departments. Also shown is a blow-up of the programs in Baltimore City that serve hundreds of families. A major focus of Maryland's home visiting evaluation is to improve the efficiency of filling home visiting slots with families most likely to benefit and to improve home visiting coordination with primary care practices and medical homes. The potential benefits of coordination between medical homes and home visiting are many. Medical providers gain a view into the family's home life, their risk factors, and health needs. Sharing information can help reinforce anticipatory guidance and advice messages, as well as care plans. Home visitors can promote appointment keeping and help prepare families for visits. They can also assist with care transitions. Home visitors can encourage use of the medical home rather than the emergency department, and they routinely conduct screenings of parental mental health, substance abuse, domestic violence, and child development, and these screening results could be shared with health providers. And if this coordination takes place, it might improve prevention, early identification, and treatment of these conditions. And ultimately, coordination may reduce care fragmentation, help improve healthcare quality and outcomes, and reduce costs. We began our evaluation of Maryland's home visiting program in 2014. The evaluation has 3 phases. In the first phase, we described the current status of home visiting medical home coordination in Maryland. We conducted surveys, focus groups, and interviews with key stakeholders, and these stakeholders included home visiting program managers, home visitors, medical home leadership, medical providers, staff, and families receiving home visiting. In Phase 2, we are working with key stakeholders to develop an intervention that enhances coordination. We are piloting this intervention here at University Family Medicine. And last, in Phase 3, we plan to leverage technology to create infrastructure that promotes and enables coordination. We are working with Maryland's Health Information Exchange, CRISP, to develop this structure. Throughout 2016, we conducted focus groups with obstetricians, primary care providers, and home visiting staff and families who receive home visiting. We asked about what home visiting programs and health providers know about the other, the degree of contact they have, reasons for the contact, whether they have policies regarding this type of contact, and their thoughts about the pros, cons, and challenges of communicating with each other. We focused on describing knowledge, attitudes, capacity, barriers, and facilitators of effective and efficient home visiting medical home coordination. What have we found so far? Well, almost all home visiting programs asked families about where they obtain their health care, and most report some kind of communication with medical practices. But there are differences by type of healthcare provider. For example, home visiting programs are more likely to communicate with the pediatric practice than with the prenatal provider or the mother's postpartum provider. The majority of that communication is to obtain immunization reports. Almost 90% of home visiting programs screen for depression, and more than two-thirds screen for substance abuse and domestic violence. All home visiting programs conduct child developmental screens. But home visiting programs rarely communicate these results to the medical provider. Clearly, there are missed opportunities. Home visiting programs report barriers to coordination that include lack of time, lack of resources, and redundant requests for record release consent. Despite these barriers, both medical providers and home visiting programs want to improve communication with each other. Virtually everyone we spoke with and surveyed thought that better coordination could improve quality, efficiency, safety, and access. Among primary care providers, 100% said that receiving information about their patient's home environment would be useful. More than 80% of home visiting programs thought that sharing mental health information with the prenatal provider would be beneficial. Most believe that sharing child development screening results might reduce service duplication. But interestingly, home visiting programs report that in general, they don't ever receive any communication from medical practices. We believe this may be due in part to medical providers being unaware of what prenatal and early childhood home visiting is, lack of knowledge that their patient is actually receiving home visiting services, and absence of an infrastructure and other resources to support such communications. Our findings demonstrated that primary care and OB providers are generally unaware about home visiting services. Providers do not know how the patient care that they deliver impacts whether their patients get connected with home visiting services. We believe that efforts to strengthen coordination need to focus on improving mutual awareness among providers and home visitors on the other's role, building relationships between organizations, arriving at agreement about the content of coordination, and establishing workflows through a designated point of contact. And ideally, the coordination should be easy to accomplish via electronic infrastructure. So let's talk about your important role in this. It is vital that you complete Maryland's prenatal risk assessment form known as the PRA. The PRA determines a pregnant woman's risk level and therefore her eligibility for services such as home visiting. The PRA is a standardized one-page questionnaire that assesses maternal medical and psychosocial risk factors that are associated with poor birth outcomes. You fill out the PRA at the first prenatal visit, and then the PRA is faxed to HCAM. HCAM stands for Healthcare Access Maryland. HCAM is Baltimore's centralized care coordination point for pregnant women. HCAM refers women into services according to risk status. When you complete the PRA, Nancy Jefferson in our office faxes it to HCAM. This slide shows an EPIC-generated PRA. In EPIC, the PRA is housed in the letter section. This letter is called Gen OB Prenatal Risk Assessment. When HCAM receives the PRA, they reach out to the patient. They offer services such as home visiting according to her risk factors. Baltimore's goal is that 100% of pregnant women have a completed PRA. Unfortunately, only 58% of pregnant women at UFM had a completed PRA last year, which is only slightly better than data for the state as a whole. What do you need to ensure that your patient gets services? Complete the PRA at the first prenatal visit, regardless of how many weeks pregnant she is. If you are seeing an established prenatal patient, check to see that she has a completed PRA, and if not, fill one out. Talk to your patients about HCAM and home visiting services. Inform your patients that HCAM will contact them and encourage them to engage in the services. If you describe and endorse home visiting to your patients, she's much more likely to accept the services when HCAM calls her. So to sum up, low-income families with young children have opportunities in many communities in Maryland to benefit from both primary care and home visiting programs, in addition to other community services. Improved coordination between home visiting and primary care medical homes can strengthen the work that both groups of providers do. When you complete the PRA, your patient is offered community-based services. Ultimately, we expect that better coordination will enhance quality of care, reduce costs, and most importantly, improve outcomes for children and families. Thanks very much for joining me today and for your attention.